Appreciate it. So as mentioned, I'm Dave Kargunla, co-founder, CEO of Aleo. Had a chance to come across the patient problem firsthand. Was headed through medical school, off to a vascular surgery residency in the US, and really saw this need to effectively solve the sampling error problem that we see very, very often, especially as we think about kidney care patients. The artificial access that's created for them fails pretty quickly, and if it is, can lead to a whole host of issues that need to be solved. And that was something that kind of drew me into the space. And as we'll talk a little bit here about kind of integrated care services, I think nephrology patients, especially end-stage kidney disease patients, are one of the most interesting patient populations. It's not like an orthopedic, hey, I got a hip implant, I'm going to go do rehab. It's very focused. They're seeing a vascular surgeon to create their access. They're seeing a interventionalist to repair that access. They're going to see a nephrologist to help manage their care. They're going to potentially see a heart failure specialist when they end up in the hospital for fluid overload, or potentially an EP to help manage a heart rhythm problem. So it's quite a lot of different clinicians, different folks that they have to talk to, have a very strict diet. Deborah's going to talk to you about that from a patient perspective. And it's a really unique and interesting area that I think can certainly benefit from a integrated care model that is potentially different than what we're seeing out there today. So to my left, we've got Ken Callahan. Ken spent about a decade in service with the U.S. Department of Health and Human Services. So let Ken tell you a little bit about himself.
Thanks, Dave. Yeah, I spent 10 years working in D.C. in the federal government, a few years working for a few members of Congress. Last position was Chief of Staff to the Deputy Secretary at the U.S. Department of Health and Human Services. The Deputy Secretary is the COO who oversees a lot of the agencies that you probably are familiar with: CDC, FDA, National Institutes of Health, and of course the Centers for Medicare and Medicaid, which is for Medicare serves our population that's 65 and over, so nearly 70 million Americans get their care through Medicare. But great to be here and looking forward to the panel.
And then to his left, Deborah.
Hi, thank you. My name's Deborah Duval. I work for Kidney Care UK, and in my role within Kidney Care UK, we are the largest kidney care charity in the UK. So we look after the 3.5 million people with diagnosed and early stage kidney disease. So in my capacity as managing editor, I look after the patient information. We publish Kidney Matters, which goes out to 20,000 kidney patients 4 times a year. And we do cover within that magazine not only patient experiences, but medical innovation and how we feel about our care. I also run a project called the Kidney Kitchen, and that is born out of my own dissatisfaction with the way I had to engage in my diet as a kidney patient, which I'll explain in a moment. And I felt very strongly that we should take the science out of the conversations with patients. We should introduce chefs and people that can be creative with our food, because most people, and certainly any woman that's been on a diet, knows you stick to it for about 2 weeks. But if you're a kidney patient, you need to change your whole life attitude towards it. So this year so far, we've had 178,000 individual visitors to the website, Kidney Kitchen. We have celebrity chefs asking to join us in the kitchen, and we video sessions. We teach patients how to do the basics like chop onions and make pasta. Kidney disease is quite an isolating experience for many people. My own history, I'm a kidney patient. I was diagnosed with diabetes when I was 11 and kidney failure when I was 28. And I've dialyzed twice for 3 years. I've had one of the very first simultaneous pancreas and kidney transplants in the country, a subsequent kidney transplant, and a subsequent pancreas transplant. So I'm a fairly experienced kidney patient, and I can see the benefits of what we're doing here at the conference. Pass you over to Rajesh.
So I'm Rajesh Prakasam. I'm a transplant surgeon from Bard's Health in London, and I do robotic transplant surgery as well. So I would say that I'm one of the surgeons who went from why to why not. I'll tell you what that means. I mean, maybe 15 years ago, you would have come to me and said, do you want to try this? I'll be saying, why? Why do I need to do it? I had that kind of mindset about technology. I was doing science, but for technology, I used to be like, why do I need to do it? And so now, in the last 10 years, I would say that I've gone on to know why not. Simply because what I got to see, the more I get engaged with different industry partners and people doing phenomenal work, is that there is an urgency in integrating technology into address our problems. So now I'm really at a space where I champion various products and work with colleagues which develop some phenomenal work. So yeah, I'm here to sort of share my thoughts on it. Yeah.
Awesome. And apologies, as the flu did ravage a few of our panel members as well. So appreciate the time everyone's made here. I think from the question of, once again, nephrology is an interesting space, right? Especially end-stage kidney disease has so many different issues, as we mentioned, that touch so many different folks. I think Deborah's already touched on it. It's not just about your clinical partners, but also even your dietitians and your vascular access techs and so many different folks. A lot of different industry partners as well, from dialysis machines to even transport. I know it's a big issue for how to get patients to a dialysis center. We certainly, even from our work at Aleo up in the Northeast, up in Middlesbrough, there's several patients that take a taxi 2 hours each way, 3 times a week, just to get dialysis. So a need for a much more care that actually meets patients where they're at, I think, is certainly important. I think a lot of times we talk about the quadruple aim. You know, for us, we talk about that from aligning the interests of the patient, physician, provider, and payer. So, Deborah, maybe I'd start with you, just in terms of, you know, as a patient, as you think about a world that can be different than what it is today, it actually has a integrated care profile that helps you manage your care better. What does that look like for you from a patient perspective?
Okay, for me, so I listed how many times I was in hospital. So diagnosed with kidney disease at 28. So in my 30s, so I beg your pardon, in my 40s. So between the age of 31 and 41, 30s, I actually spent 23 and a half months as an inpatient in hospital. So that's 2 years of my life, of 1 decade in hospital. Valid reasons: transplants, peritonitis, meningitis, all the things that we kidney patients have to deal with. But also, what I didn't monitor was how much time, in my eyes, a lot of it wasted, I spent driving to and from hospital to sit in an infectious A&E department because my fistula wasn't functioning properly, or I didn't think it was functioning properly. So not only was part of the promise of a transplant for me was regaining a normal life. But even post-transplant, I can have an appointment with a diabetes team, and another appointment on another day with a GP, another appointment another day with my renal team. I'm to and from the hospital several times a month, and I'm successfully transplanted. So you can triple that as a dialysis patient. So I had to take responsibility for making sure that all these different people were monitoring my care. And I want to see a world where the model is that all of those people get to know me and my needs. Now, the promise of a transplant came along with a normal life. And I have always worked full-time through dialysis, through transplants. I work for a very understanding employer, Kidney Care UK. They value my experience because it helps us provide patient information for the people we look after. But I couldn't go and work for a bank or an office or anything else. I could only be self-employed or work for a charity that understands kidney disease, because nobody else does. So if I can manage my condition at home through digital technology, and it's managed consistently, not just once every 3 months, I'm going to be a fitter, weller patient. My quality of life is going to be enhanced. So we're all winners, and I'm going to save you money. So do you want me to elaborate anymore? I'll pass that over to you, Rajesh.
Yeah, I mean, Deborah touched upon that fact that we always worry about cost when it comes to providing service. Although we don't talk about it as loudly as we want to, it is undercurrently, it's there in every discussion. The way to save money is move the care away from the biggest investment, which is a hospital building, and the most expensive resources, which are doctors. So therefore, the only time when we move it out of that, you start looking at saving money. With regards to the ICS, kidney failure is the perfect model for an ICS, because the patients need diabetic care, bone care, skin care, all those things, foot care, for example. All these things has to be there. And quality of life, you touched about, Deborah, it's something which, ashamedly, we started measuring it only in the last 15 years. And simply because we thought keeping somebody alive is good enough for the patient. That's what we thought. and I did a paper about it where we asked patients who lived 10 years after a liver transplant who would have been died, if you go back in time, how many of would have wanted to have a transplant and stay alive? 43% said they would prefer to be dead. This was a paper we wrote in 2004. So it really scares us that we are underestimating the impact of ICS remote care, where the patient can regain their life, not being alive. So therefore, that's why I think it's really important that we do that, yeah.
And Ken, I think from your experience as well, right? So for many of you that may not know, so effectively in the U.S. we've had only one aspect of U.S. healthcare has effectively been single payer, but in the traditional U.S. way of even making a mistake on that front, it's effectively still been fee for service and very much been focused on delivering dialysis, not on delivering care to patients who happen to be on dialysis, right? And I think that was something that you certainly tackled within the first few months, and which led to the Advancing American Kidney Health Initiative. But I think there was a realization between you and Eric when you first got in that there had to be a new way of integrating care, and that's led to a few different models. But curious, what led to that decision, and then what were the ways that you were able to stimulate a progression to a new care model?
Yeah, just adding on that. So yeah, Medicare spends every year over $1 trillion, and 1 in 7 of those dollars is spent on dialysis patients. And another thing to mention is, for most of Medicare, you have to be 65 or older to be getting care as a Medicare beneficiary. End-stage renal disease is one of the few exceptions. So whether or not you're 35 or 30 or 40, whatever age you are, if you're on end-stage renal disease, Medicare or the government is going to pay for it in the single payer system. So one thing we looked at was just the human cost. We have 850 to 900,000 people right now in the U.S. in dialysis, 35 million more people who are on the verge or might already have chronic kidney disease who could easily be on dialysis in the near future. So we knew we had to look at ways to incentivize it and ways to find ways to improve the care. So we did a few things. We changed payment models. So we incentivized nephrologists and dialysis centers to the higher quality that they got, the more money that they got. And it so far has worked really well. We also created something called Kidney X, which was the largest public-private partnership in history about how to deal with kidney care. And we gave out almost $100 million in prize money to people who had never really thought about kidney care. And we got all sorts of ideas. Some were good, some were not so good. But what was good was people who had never really thought about it were thinking about ways to innovate in the space. And that's actually how I met Dave. Dave was one of the applicants at the time, and it was an easy choice at the time to give Alio, who has a remote patient monitoring device. We gave them $1 million because for the first time we had heard something that the patients always talked about was they didn't want to have something inserted in them again and again and again, and they wanted to have the peace of mind to know that if there was, God forbid, a situation where they'd have to go to a hospital or, something was going on with their blood pressure or potassium levels, that someone would be able to track it. And so it made sense for companies like Alio and a bunch of other companies who are really trying to change the status quo. But, over the last few days, it's been great to learn about what's going on here, and hopefully we're able to kind of share our successes and also what's not worked to improve kidney care for everyone.
So part of what brought us here to the UK was, one, an unmet need call, which we responded to. So the HSN for North Cumbria had a group up in Middlesbrough that was the Southeast Trust had been sending nurses out to patient homes to do a point-of-care blood draw, get that data. That is very crucial for these patients. Even though that's federally mandated in basically every first, second, third world country across the world, typically only happens maybe once a month, once every 3 months. and they realized that if they could do this on every off dialysis session day, they could actually reduce the cost of hospitalizations and reduce the number of hospitalizations. But as you might imagine, that's not a very scalable solution, right? Having to hire 5 extra nurses, some who are driving 50 miles each way to a patient, just isn't going to necessarily work out. Let me ask a question then too, a little bit from the clinician and patient perspective of, we've seen the rise of RPM in telehealth, but maybe what are some of the pitfalls from a design perspective, what are the things that we can watch out for now that may actually hinder adoption of more integrated care models that are potentially there today?
So that's the key thing for us to reflect on it, because it's exciting that people who are agreed and who are converted, they will use it regardless. I think for us in our population, 30% of patients, they will use it. They will accept the challenge. But what the rest of the 70% needs is a product which is very robust. It has to be tough enough to use because it's a physical device. It has to be sort of easy to use. And at the same time, it has to be less intrusive as well. So those are the physical characteristics it has to have for a person to believe that, like an Apple Watch. I mean, still on the watch, I have to wear a shield on sometime because it breaks. So whatever the device is, it has to have that resilience built into it. Then the question of how the data is collected, shared, and stored. Those 3 has to be extremely transparent. Because that's one of the biggest difficulties. Often patients and healthcare providers, we fear that what's happening to the data. And there are enough stories we all know about the data sharing and the problems with it. So if there is a transparency from that model, that would make it very easier for people to adopt. And the final thing is about the organizations and integration into the existing healthcare systems, what we use. I think that is where a lot of us during COVID, we adopted some of them and we didn't really fully integrate. We used standalone tools. So we are becoming adept and agile to use standalone tools. That means there are some technology which has to be integrated into what is there. Some of them we don't have to, because we are getting used to being tech familiar and adopting those tools. One of my patients has an app about their weight and blood pressure. I use that data. They send it to us, email it to us, the image of the series of blood pressure. It is a much better information than a one-stop blood pressure check in a clinic. So therefore, these 3 factors has to be thought about and built in for it to be integrated more easily. Yeah.
Okay. So pitfalls, as a woman, okay, first and foremost, not a patient. I feel like my whole life I've been treated as a condition in the hospital and not as a woman, and that's a really sore point for me. So any device would need to be aesthetically acceptable to me. So I already wear a Freestyle Libre on my arm. For those of you who don't know what that is, it communicates with my mobile phone and it monitors my blood glucose all day. So all I have to do now is waft my phone over my Freestyle Libre, which is a little disc on my arm with a little tiny filament that is underneath my skin. And that data then is already transmitted to my diabetes team in hospital. So this is an extension of that. So what I don't want to have is loads of devices attached to my body, like I still just want to be a person. But so that's one pitfall. The other is that I would still want a relationship with the consultants that look after me in the hospital. So I wouldn't want that totally removed, but I would want the burdensome side of that relieved a little bit, so that they're aware of me, we've got consistent data, but that I still have the opportunity to actually have a face-to-face appointment with them, because that personal connection is still very important. So I wouldn't want to lose that altogether.
And what does that mean for you, Deborah? And just in terms of, we've talked a lot about how, once again, this patient population in particular sees so many different clinicians.
Yeah.
We're seeing the rise of chatbots and different ways to communicate with different clinicians and ask questions. And we hear a lot about it from the physician burnout side of, hey, I'm not getting paid for all the time I spend in my electronic health record and responding to messages. What does that mean on the patient side in terms of how much information you want, or how you want to interact with that, and how you want to interact with your clinicians?
Well, there is no such thing as a patient, if you like. We're all as different as everybody in this room. We're all individuals, and we all have individual strengths and weaknesses. So I think that there are going to be some patients that are afraid of technology, maybe their age, their education, whatever, and you'd have to overcome that burden. But for those patients like me who just want to get on with their life, I think this is the absolutely only way forward, and I hope that it is embraced by ICS, that we have an integrated care package for us as a patient, and that I'm not just going to see all these different people in the hospital who often don't even speak to each other. I think that as the more technologically aware generation moves up now into the chronic kidney disease, is predominantly an older person's disease. I think there will be an expectation that we rely on digital. So it's not acceptable. What we are currently doing is not acceptable, and we're getting more patients going into hospitals. That exposes us to more infection. So there's an expectation that this is the way forward. How you actually move that into reality, I don't know. But you will have some patients that won't want to embrace it. It's a case of speaking to the people that really need this change, that really just want to live a life. We can live a normal life around chronic conditions. And the most important revelation that I've had with this particular device is I must have had hundreds of thousands, if not millions, of needles in me, and I don't want any more. It hurts. Like, give me a break. So that's the most important for me.
She just said it, Deborah has gone through that for a long time, but still it hurts. And that just means that it's not a solution of doing the same thing again. And also with regards to the physician burnout, that's a key issue. We all need to think about it. And actually, one of the things we started reflecting and doing is, instead of working harder and harder and harder, we started looking at how we can work smarter and smarter. That's the biggest change in the healthcare from where I am involved in, from the surgical side and robotics and everything. And the way the smarter working got better is simply because of the aid of technological solution. It's not another 10 surgeons or 10 medics. So therefore, the burnout is going to be there. It has to be looked at, and it is being looked at. The solutions, what we are looking for is really to maintain the service, enhance the care, address the increasing numbers, but protect the people who are delivering it by other means. So therefore, I think working smarter with the aid of the solutions is the way forward, I think, yeah.
I think one of the questions that comes up in the ICS, and you brought it up a little bit, is there's a question on equality, and I think also equitable access. In the U.S., there's the prevalence of kidney disease is much higher in the African American population. That was something that we had to be very thoughtful of in developing a wearable. I think there was a cover article in The Economist about a year ago during kind of in the height of COVID, and then it asked the question: Are pulse oximeters racist? Right? And then the answer is, well, kind of. And the reason for that is they don't actually take into account skin color when they take a reading, and they unfortunately for darker skin tones will often overestimate the actual pulse ox reading. And that's actually quite a problem, if you will, in terms of how do we actually assess patients and meet them where they're at. Certainly was something that as a wearable company we took into account as we built out our algorithms, was to actually account for that each time we take that data, especially given the fact that we needed to be able to meet our patients no matter where they're at. It was something that we thought about in terms of people ask sometimes, for this patient population being a chronic disease population, why do we use a cellular-enabled modem rather than a smartphone? Was given the socioeconomic status, et cetera, that you kind of mentioned, being able to help that as well. Ken, I think you tackled some of that initially, I think, as well from a policy standpoint. If I'm not mistaken, I think HHS and I think the FCC, kind of the communications component in the U.S. actually partnered together to enable more bandwidth in rural areas. I think you worked with a lot of the Native American tribes as well too, to ensure that they had broadband access, and a key component of that was RPM and telehealth. So you maybe want to talk a little bit about how that spurred some of the equitable access components.
Yeah, so one of the agencies at HHS is the Indian Health Service. Provides direct care to nearly 3 million Native Americans in the U.S. who unfortunately have a much higher prevalence of diabetes and end-stage renal disease compared to the population at large, for a number of reasons. But problems that they've had is they're oftentimes in very remote areas, and how do you get them access to care, especially to specialty care? It's already hard enough to staff some of the reservations, but how do you make sure that you get them the care that they need? And one of the ways we were able to do that is by, first off, directly talking to the tribes. We had multiple listening sessions. There's almost 560 tribes in the U.S., so come from, all sorts of different areas, different backgrounds, different cultures. So listening to them, understanding their needs, and we were able to design ways to, as Dave mentioned, extending the broadband capabilities, expanding different funding. We increased the funding for it by nearly $2 billion every year to help address some of these issues. And then also, we helped them build different dietary plans that were still, addressing what they needed to do within their culture and being culturally sensitive to what they wanted to do. There's still ways to go, but these RPM devices definitely kind of help level the playing field because everyone can have access to them once the broadband capabilities are expanded.
And also then kind of building on that, a little bit of it is changing the way that some of these devices are reimbursed and somehow how that happens. Obviously, once again, kind of from a U.S. perspective. But here, once again, as I kind of mentioned, kind of the reason that we came here is we saw that Rajesh is from a, it's interesting that renal care is kind of, I think, one of the only positive from a cash flow perspective to a lot of trust, right? But there's still a lot of cost that comes into the system that you have to pay attention to, be sensitive of. Obviously, from BARTS, you're looking at it from the complete opposite end of a very urban setting, but you still have some of the very similar challenges in terms of for equitable access to care. What does that look like, at the, from a remote end? We can think about broadband, we can think about making sure cellular modems or whatever it is to meet patients where there are. What does that mean in an urban setting as well, too?
Yeah, I mean, equity to care is a big problem. I think simply because I think during COVID, it became very obvious that not everyone was having access to the care what they need in a timely manner. People do get care. It's the timely is the big issue there. So therefore, I think any company which want to address this issue, they have to include that in their development or early phases in. Because otherwise, it's very difficult to get a product or a solution, then start working with it. That's a challenge we often face. And that's one of the reasons organizations or healthcare providers are not keen to adopt to that solution. So as long as we don't really, when we started working with us, I didn't really want an end product. I just wanted them to be aware of that problem so that we actually help together in addressing some of those things. So therefore, that's the first thing. Second thing is actually understanding the need for the individuals, like what you touched upon, Ken. It's the cultural issues. Just simply having a sort of an app in our trust, which translates the information to 80 languages, we increase the rate of organ donation. That's how simple it is, and that is just one app making a change to our information leaflet. So therefore, I think it does a lot of times. I think we worry that it needs a lot of prime capital cost. It's not. The industry who want to commit the solution, we want them to be aware of those issues so we can work together. Organizations need to be assured that it is something we need to do, and that is something which has happened. After COVID, particularly in UK and Europe, it has become a big problem that the equity to or access to timely care is going to be measured and will be assessed on it as well. So I think it's the right time to engage these kind of solutions into our practice. And finally, I would say from the patient's perspective, the patient organizations are the key in getting these things through. Deborah is involved in one of the largest organizations in UK. I have my own hospital patient group. So anything I do, the first discussion I have with the technology is I talk to them first. What do you guys think? So I do a peer review with them first, then I ask my staff. Because if they don't believe in it, they don't think it's not going to be useful, there's no point at all. And that conversation is becoming more and more as well. Yep.
So I know we're coming up to the end of our time here. So maybe just with the last word from each of you, I think there's I'm kind of paraphrasing the Charlie Munger quote of, show me your incentives, I'll show your outcomes, right? So from that perspective, from the policy, patient, physician perspective, maybe just if you had to change incentives or incentivize maybe one or two components differently to enhance the adoption of an integrated care model, from a policy level, from a patient level, and from a physician level, how would you do it, and what incentives would you change?
You doing first? Sure.
Yeah, so, the U.S. healthcare system is notoriously fragmented, which can be good in some ways because it can lead to different bubbles of innovation around the country. It can be hard and problematic in other ways because it's hard to make changes when they need to be made. The changes need to be incremental, or they need to be done through legislation as opposed to a government agency doing regulation. So one thing that I think we did a pretty good job, and the folks who are still in the government are doing a good job, is moving the freight ship of continuing to reward people who are producing better outcomes, continuing to understand the cultural sensitivities of people, whether they be in urban centers or Native Americans in very rural areas. And then also just continuing new players and new people to come into the space, like KidneyX, to continue to increase the money that's given to new grant money for kidney patients. And that just needs to continue to happen because we need as much brain power and as much creative thinking as possible to help tackle some of these issues. And and seeing what Aleo Medical and this non-invasive remote patient monitoring device can do is a great step. But I think there's even more. I think there's other ways we can continue to expand it. But the rewards and money has to be kind of helping drive that too.
I made 30 seconds each. Leslie.
Okay, so for me, Rajesh just touched on something which is actually very relevant for me because I'm not near a big centre. I live in Cornwall, and my hospital is 29 miles away, and that's not even a transplanting hospital. My nearest transplanting hospital is over the border in another county. So I actually do firmly believe, and I know this, that a high proportion of patients choose conservative care. They choose not to dialyse. They choose not to be treated, just to have their condition managed, because the travel and the involvement of the hospital is just too much to comprehend. So one massive benefit is you remove that burden from them, and with digital technology. But secondly, the quality of my transplant will be enhanced. So at the moment, I'll have tests I insist on every 2 months, but that's only me insisting on that. Normally, we have blood tests every quarter. So 4 times a year, we have blood tests. We go and see all our different consultants, and then we don't know, we can get our results, but we don't know that anything goes wrong between appointments. But this consistent monitoring of our condition, blood results, fistula flow, to have that constant monitoring in place means that there's a very good chance our transplants will last longer, be better quality. We won't be coming back into hospital to go back on dialysis and have another transplant so frequently. So it's hugely important.
I'll just say a few words, really. It's timely that we need to do it. Second thing is it's going to be difficult to get through NHS. Don't stop trying because the door is just open. Post-COVID, we are more open to look at these things, but it is challenging to find the right champions to push it through, but it's definitely possible.
Thank you, everyone. Really appreciate it. Thanks.